here today. My name is Christopher Canning, and I'm the Director of Research at the Waypoint Research Institute. It's my absolute pleasure to welcome all of you here today. This is our third Waypoint Talks of the year. We host many of these events throughout the year, and this is our third one, and it's our first one of 2024, and it's really great to have you here today. I'm glad you can join us to hear about a really important research project looking at novel treatment modality for people who use substances from our VP of Research, Dr. Bernard Lefol, who I will introduce in a moment. So for folks who haven't joined one of these before, the Waypoint Research Institute is an embedded research unit within a specialty mental health hospital. We conduct research in many different areas, including forensic mental health, implementation science, child and youth mental health, and substance use. Our team is comprised of over 40 staff and students, including support staff, research scientists, clinician scientists, administrative staff, and other researchers and trainees who are with us through scholarships and academic appointments. But before we begin today, I would also like to acknowledge that the Waypoint Research Institute is located on the traditional territory of the Anishinaabeg, which include the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee, the Huron, Wendat, and Métis peoples. We acknowledge and affirm our commitment to improving relationships between nations and to improving equity for Indigenous communities residing in the Central North region of Ontario. And we also invite you to share the traditional territory you are joining us from today in the chat down below. If you're unsure which territory you are joining us from today, we encourage you to check out native-land.ca. That's native-land.ca to find out which territory you're joining us from today. A reminder that Waypoint Talks is a webinar series offered through the Waypoint Research Institute. These were on hold for a number of years throughout the pandemic, but have got back up and running this year. And we do a couple things. We highlight some of the practical implications of research projects. And I think today you're going to hear some of that through Dr. Bernard Lefol's research. Our complementary series, Waypoint Talks Building a Research Toolkit, looks at highlighting best practices used in mental health research, quality improvement, and program implementation that you may take back to some of your locations across the country or the province. These events are open to all who are interested in learning about emerging research, best practices, and clinical innovation. So it's great to have you here today, as I said. Okay, a couple housekeeping items to note. I'm sure many of you over the years have been on lots of Zoom webinars, but in case you're wondering, if you do want to chat, you can type your chat to the participants in the chat box below. You can pose questions to the presenter in the Q&A function, and our KT coordinator, Christy Allen, will jump on later and help facilitate some of that dialogue when the presentation is over. We will have lots of dedicated time at the end for questions and discussion, so we encourage you either to drop them in the Q&A section or hold them until the end. Entirely up to you. They may come up as you hear the talk. A reminder that the recording and slides will be available on our website after the event, so you can check back or you can send them to colleagues who you think might be interested. And all of these are hosted on our WRI website. We encourage you please to complete the post-event survey. This helps us improve what we do and make these webinars stronger. So we really appreciate the feedback, and any feedback is good feedback. So please take your time to do that. And if you are looking for an attendance certificate for professional development, please contact us and you'll have a little more information from Christy at the end on how to do that. Okay. Most importantly, we are here today to listen to our speaker, Dr. Bernard Lefol. As I mentioned, he's our VP of Research and Chief Scientific Officer at Waypoint. He joined us in February 2022, which is just coming on 2 years ago, which is wild how fast that time has gone, but here we are. Dr. Lefol is a clinician scientist specializing in drug addiction. He is the chair of addiction psychiatry at the University of Toronto and is a professor in the Department of Psychiatry, Family and Community Medicine, Pharmacology and Toxicology, as well as the Institute of Health Policy Management and Evaluation at the Dalla Lana School of Public Health. Dr. Bernard Lefol has practiced in the area of addiction medicine at the Centre for Addiction and Mental Health in Toronto since about 2006. His impressive multidisciplinary research approach seeks to better understand the neurobiology of addiction and develop novel treatment therapeutic strategies, which you'll hear about today. So really great to have Bernard here for this presentation, and enough of me, and over to you, Bernard. Enjoy the talk.
Thanks, Christopher, for the introduction, and hello, everybody. It's a great pleasure to be here with you. So today I will be talking about deep TMS as a novel treatment approach for smoker, and it will be mostly covering like how this novel treatment modality came to life through some basic discovery initially to some practical application. So I will start with some disclosure. So my funding comes primarily from public agency and grants, and I got also some support from industry in some project. What is relevant for this talk is that I got some I will present some work that has been funded by a grant obtained through Pfizer, and also the company Brainsway provided me brain TMS coil at no cost. Okay, so I will be talking about a brief introduction on the neurocircuitry of addiction as we currently understand it. And then I will focus on the role of the insular cortex in nicotine addiction. And this role will be covered through some lesion studies, inactivation and deep brain stimulation studies, and transcranial simulation studies. Okay, so how do we perceive drug addiction? So we perceive this through different phases. And you have the phase that we call incentive salience, which is I want more of this product. And that is because drugs of abuse typically induce initially pleasure, reward, and then there is this reinforcement mechanisms that build from there. But after some time, usually people develop what we call physical dependence and withdrawal symptom, which means that people start to feel bad when they are not taking the substance and develop some negative effects and sometimes physical symptom of withdrawal. But you have also along the way the craving and desire to take the substance that also develop. And this is based more on the level of executive function. So those three phenomenon typically occur in someone that has developed substance use disorder. They are all present in parallel at different extent, and they all contribute somehow to the maintenance of the drug-seeking behavior.
Bernard, sorry to jump in here and interrupt. Your slides are not available to the attendees, so I don't know if you've shared them or are planning on sharing your slides. We have a couple comments in the Q&A to put them up.
It's good to know. Okay, hold on. Is it better now?
I can see them now. If you go into presenter view, it will show your next slide the way I'm currently seeing it, Bernard. That's the one. There you go. Thanks.
Is it good now?
Yeah.
Okay. Okay, so I think I mentioned initially like the disclosure, so I will show very briefly the disclosure slide again. So the relevant disclosure here is that I got a coil from the company called Brainsway. That's the presentation. I will be talking about neurocircuitry of addiction and covering studies ranging from animal study to human studies. And this is the presentation of the different steps that are present in someone that has developed a substance use disorder. So the first step will be induced by the incentive salience, so created by the pleasurable effects produced by substance of abuse. So, and that's creates the initial step usually of the substance use disorder. After some time, people will develop withdrawal symptoms when they are not exposed to the substance, and that will contribute to the maintenance of the substance use. But you have also some executive function deficit and cravings that increase the desire to take the substance. So all those three phenomena are present in someone that has developed substance use disorder. And what you can see in this slide that is coming from a very well-written article from Strang et al. Is that those different phases of the substance use disorder, they map to different brain area. And so you can see here the color of the brain areas that are involved in each step. So on the right, you can see the human brain. And you can see, for example, at the center here, you can see the nucleus accumbens. So this is what we part of the brain reward area. So this is where typically all drugs of abuse produce their initial effects. So stimulating dopaminergic transmission, elevating dopaminergic transmission in the nucleus accumbens. So this incentive salience reward pathway typically involve habit learning and reward system. So this is based on basal ganglia neurocircuitry involving nucleus accumbens and dorsal striatum. You have also in red the deficit pathway related to the withdrawal. So drugs of abuse typically engage this system after repeated chronic use. And this is involving also partly the nucleus accumbens, but other brain area like central amygdala or the beta nucleus stria terminalis. So those are typically involved more secondarily in the development of substance use disorder. And then you have also the craving circuitry that involve different, mostly cortical area. And this is the orbitofrontal cortex, the ventromedial, ventrolateral, dorsolateral prefrontal cortex. So there have been lots of attention put on those cortical area in terms of the ability to control the desire for a substance. And I will be talking a lot today about a brain area called the insula that you can see here, which is a part of the frontal cortex also. So what is special about the insular cortex? So this is part of the cerebral cortex, but it's a little bit more deeper. And it is divided typically into the anterior and posterior part. And this insular area has been involved in multiple brain function, notably feelings of anxiety, pain, cognition, mood, threat recognition, decision-making, but also very importantly, homeostasis. So it is really a node for interoception. So feelings, internal feelings, for example, cravings, will converge to the insula and then get projected into other brain area to be processed. And this is an area also involved in the conscious urges. So why is insula such an interesting area? So it came from a paper that was published by the group of Antoine Béchara in January 2007 in Science. And what they did in this paper is report some study performed in human subjects that had a stroke, and the stroke, a brain stroke, destroyed some of the brain area in those subjects. And so what the team here have observed is that if the stroke hit the insular cortex, and this is shown here on the red area, this is where the insular cortex will be, this stroke destroying the insula would lead to a disruption of an addiction to cigarette smoking. So how did they came to this conclusion? So they took people showing up that were smokers that had brain stroke, and then they checked, is this stroke resulting into a damage of the insula? Will it be total insula, like right and left? Will it be only a stroke hitting the left insula or the right insula? And then they define disruption of smoking addiction has the ability to quit smoking easily, immediately, without relapse and without urge to smoke. And you can see clearly here, those are the number of subjects they have studied. You have, if the stroke hit a brain area that was not the insula, you have some people that were able to quit smoking, but not really a majority. But in contrast, and you can see that in red, in the subjects that had total insula or left or right insula lesion, those people were able to quit smoking with disruption of smoking addiction. So that was quite an exciting finding. There have been also another paper following that, looking at a follow-up study of people following a stroke. And here you can see their nicotine addiction assessed by the Fagerstrom test of nicotine dependence. And in that study, they have looked at subjects that had a stroke, either in basal ganglia area, basal ganglia plus insula, or a brain damage comparison, which was non-involving those two areas. And clearly here, what they found is if the stroke hits the insula associated with the basal ganglia, there was much more reduction also of nicotine addiction. And you can see this effect was maintained over a prolonged period of time. So those findings were really exciting because before that time, very few people paid attention to the role of insula in nicotine addiction process. But following this paper from Bechara group, then people look back at some imaging studies that were performed in addiction, and that's a paper that came at that time. So there have been many more studies here, but this is a paper from 2010 here. And mostly they looked at the brain area activated when you present to people with substance use disorder, cues associated with drug taking, and then you produce craving. So it's known that those type of exposition like activate specifically some brain area. And typically people had paid attention before on the impact on the anterior cingulate cortex, for example. That was the main area that people were interested in, also the amygdala. But looking back at all those experiments, what they were able to realize is that also in all those studies, insula was activated. But people really didn't pay attention at the time because insula was not part of the neurocircuitry that people were looking for. So at that time, and that was like 10 years ago, we decided in the lab to explore those findings more specifically, because, you know, in human study, when you have a stroke, the stroke rarely just hits perfectly the insula. So you have always lesions that is on the insular cortex, but could also map onto some other area. So it's very difficult to make sure that the effect that we see are really mediated selectively by the insular cortex. So we decided to test this using preclinical model, and here model using rats. So the model we use, like you can see on the left here, is a model called the rat self-administration. So you put rats into operant chamber. So the rats have been previously implanted with a catheter, allowing them to self-administer a drug directly into their venous system. And then they are put in operant chamber, and those operant chamber are equipped with levers. And when the rat will press on an active lever, it will trigger the infusion of a shot of drug, and here nicotine, for example. And you have also an inactive lever in those chambers, and we are also able to use light cues that will turn on during drug delivery so that they get paired with the effect of the drug and become conditioned stimuli. So what we decided to do at the time was to test selectively the impact of an inactivation of the insular cortex. So we put cannula that directly went into the brain and targeted the insular cortex. So that's the area that is just below the purple line here. And we decided to test the effect of infusing a mixture of GABA agonists, so baclofen, mucimol, which is a very well-established procedure to inactivate selectively a very small brain area activity. So what did we do to test the nicotine reinforcement? So we first trained the animal to self-administer nicotine during a training phase. So typically the rat will rapidly learn to self-administer nicotine over several days. Then the behavior will stabilize and become more or less stable over several days. And then you can start to test the impact of the intervention on this stable behavior. So that's what we call the testing on nicotine taking. We also can test the drug after extension. So in that case, what we did is we first trained the animal until the behavior stabilized. And then we decided to remove the drug and the light cue. So those two things are not available anymore when the animal goes in the cage. So what we see is that there is an extinction phase happening over several days, and then the behavior will become extinguished at very low level. And then what we can do is reintroduce in this operant chamber the cues or produce a drug priming, and that will produce a reinstatement of drug-seeking behavior. And this is a model mostly of relapse, because it is very well established that smokers will relapse to smoking when they are exposed to cues previously associated with smoking behavior, or when they will get re-exposed to a priming, like use of a cigarette, for example, will lead to more use secondary. So those are the findings of those experiments. So you can see here the impact of the inactivation of the insular cortex. So here it was a granular insular cortex. So when we perform like vehicle infusion, so which is a control, you can see here on the top left, self-administration behavior was around maybe 18 infusion of nicotine in 1 hour session. And after insular inactivation, the self-administration behavior was significantly decreased. So this is measured under what we call fixed ratio 5 schedule of reinforcement, which means a rat had to press 5 times on a lever to get a single shot of nicotine here. And we did control experiment on animal trained to self-administer food pellets, and you can see that the insular inactivation had no impact on the ability of the animal to lever press for food, so suggesting that this effect is a non-selective effect. So we also tested the impact of insular inactivation on the motivation to self-administer nicotine under what we call the progressive ratio schedule of reinforcement. So under this ratio requirement, like after each infusion of nicotine, the number of lever press required to get the following infusion is increased, and that will increase with an exponential manner. And so when you test the animal under this paradigm, what happens is at some point the effort related to get the nicotine infusion is too high, and then compares the value of the reinforcement, and the animal will stop responding, and that's what we call the breakpoint. And you can see here on the top left, the breakpoint was around like 9 infusion for nicotine, which correspond to an animal willing to press around 100 times, 120 times to get a single infusion of nicotine. But if you inactivate the insula, there is much less motivation to get nicotine. And very interestingly, in this experiment, we compared to the saline substitution. So we removed nicotine from the syringe and tested like what happened when we use saline instead. And you can see the substitution to saline was equivalent to the inactivation of the insular inactivation, suggesting that most of the reinforcing effect of nicotine were completely abolished by inactivating the insula. And in contrast, on the bottom, you can see here, there was no difference in the motivation for food. So then we tested the impact on relapse behavior. So this is, you do further extension. So you can see here what is called BL baseline the responding of the animal is very low at that point, then you can reintroduce a nicotine priming on the top left that produce reinstatement of nicotine seeking, and this is blocked by the insular inactivation. The nicotine cue reintroduction will also produce reinstatement of nicotine seeking. This is also blocked by insular inactivation. And in contrast, you see no impact on food seeking behavior in this paradigm. So those set of experiments clearly indicate that insula selectively control in rats trained in this paradigm the motivation to take nicotine, but also the relapse to nicotine seeking. We also did some control experiment testing another part of the insular cortex or the granular cortex, and mostly we have shown here that also you could decrease motivation for nicotine by inactivating this brain area under the fixed ratio schedule, and also you had a reduction of the reinstatement of nicotine seeking. So different part of the insular cortex in rodents, at least clearly here, control nicotine taking and nicotine seeking. So the question after that was, if you inactivate a brain area with an infusion of GABA agonist, it is not really something that is very physiologic. So it's not something that we see in patients that we infuse directly GABA. So it's a good tool to test the role of this brain area, but it's not really something that reflects something useful in therapeutics. So then we decided to test a different way of modulating this brain area activity, and this is by using the deep brain stimulation. So deep brain stimulation, it's a technique that has been used a lot in Parkinson's disease. You know, subjects get implanted an electrode in their brain, and that can restore some of their functional abilities in case of Parkinson, but also some other disorders. So we decided to use similar stimulation parameters at what is typically used in Parkinson's disease treatment, but instead of going for basal ganglia, we decided, okay, we will go for implemented the animal with electrode directly in the insular cortex. So we did the same type of experiment, and you can see here the impact on nicotine self-administration under the fixed ratio 5 schedule of reinforcement. So when we did the sham stimulation, there was no significant effect, but then when we did the DBS activation, there was a significant decrease of the nicotine self-administration. But you can see here, the saline substitution was decreasing behavior even more, so which meant that the DBS was less effective as an inactivation to decrease the self-administration of nicotine. But there was no also impact on food taking in that experiment with DBS of the insula. Those are the results obtained for the measure of the motivation for nicotine under the progressive ratio schedule of reinforcement. So you can see on the left that the stimulation, active stimulation, significantly reduced also the motivation for nicotine, but again here to a lesser extent than the saline substitution. And on the right, you can see there was no impact of the deep brain stimulation on food, on motivation for food under the progressive ratio schedule of reinforcement. And those are the experiments on the nicotine relapse paradigm. So the reinstatement of drug-seeking behavior induced by cue presentation on the left, that was reduced by the DBS of the insula. And similarly, the effect of a nicotine priming injection was reduced also by the DBS of the insula. So altogether, those experiments suggest that modulating the activity of the insula by deep brain stimulation could be an effective way to modulate the motivation for nicotine and decrease potentially relapse for nicotine seeking. So now I will be going back to the human subjects, and parallel to us doing those type of basic experiments, there have been also different teams working with other approach to test the role of the insular cortex in smoker. And I will just mention, not go too much into details, some of those experiments. For example, here, an fMRI experiment done in human smoker, showing that when you present environments that have been associated with smoking behavior, there is an activation of the hippocampus, so which is, as you know, involved in memory, but also of the insular cortex. So this is very interesting because, you know, that validates the role of the insula, like in smokers. But you have also other groups that have gone a little bit further to see, like, is that activation also related to the ability, for example, of a smoker to quit smoking. And here, this group, like Francis McClernand, used also fMRI and then used a brain functional connectivity paradigm, like testing like how different brain area activity relate to each other. Mostly you can, you know, see in real time, like how brain area get activated, and you have, and it is not random in the brain. So you have networks of brain areas that are activated at the same time. And that's what is called functional connectivity. And interestingly here, they have shown that based on the connectivity between the insular cortex and the motor control areas, people that have less connectivity, it will affect their ability to maintain abstinence. So another study here showing that functional striatal connectivity associated with improved cessation outcomes. So there have been like a series of studies. So this one was smoking cessation induced by varenicline, which is a Champix medication that is used for smoking cessation. Okay, so this is just a selection. There have been at this time way more study published on the role of insular cortex in addiction, but I just wanted to show you a few of those. And mostly going back to how we could define, you know, the different level of intervention, and you have, you know, in every subject, everything starts from the genes that then will code for molecules that then are composing cells that are connected through circuits, and that will affect physiology, behavior, and then the subjective feelings we can collect in human subjects. So typically what we are doing currently in smoking cessation is we try to affect the behavior, like you see here on the top, through some counseling primarily, and would be cognitive behavioral therapy or relapse prevention counseling, but that's how we try to affect behavior, by talking to people. But we also use pharmacology here on the bottom to take drugs such as varenicline, nicotine replacement therapy, or bupropion, because those drugs have shown to affect some neurotransmitters and then modulate some function related to addiction, for example, decrease craving or decrease withdrawal symptoms. But now we have, through device-based neuromodulation, the ability to affect directly brain circuits. So that's what I will be talking about. And so, you know, we have, at the present time, different modalities that have been developed. And those modalities are reviewed here by Deng et al. In 2020. It covers like all the range of approach. So you have, you can see here, like it's listed based on the invasiveness. So you have the most invasive approach, for example, is deep brain stimulation, where you have to drill a hole in the skull and implement an electrode. But you have also less invasive like ECT, that is, creating convulsion to treat a patient, primarily used for depression. But you have also more recently technique called TMS, or transcranial magnetic stimulation, that has been developed. And TMS allow to modulate the activity of some brain cortical areas through a magnetic field. And you have what is called the deep TMS that I will be talking about today, because deep TMS is using a coil that allows to modulate activity of brain area a little bit more deeper in the brain. So how is that working? So it's mostly using a coil, and through this coil, you will bring some electrical activities that will then generate some fields that are able to modulate the activity of brain areas that are positioned just below the coil. So, and you can see here, for example, on the right, a picture of the brain sway device. So the subject will wear this helmet, and then you can select the parameters you will use to create those magnetic stimulation. So I will be now talking about work that was led by Abraham Zangen. He's working in Israel, and they have decided here to test the impact of TMS targeting the prefrontal cortex and insular cortex, so using the deep TMS. And in this experiment, they decided to use a low frequency, so 0 Hertz, control condition, 0 Hertz, or low frequency or high frequency brain stimulation, so 1 Hertz and 10 Hertz treatment. And they use smokers that got different deep brain stimulation, like stimulation. And you can see here the impact on that study on number of cigarettes smoked per day. So there was clearly much stronger reduction on the number of subjects that got the stimulation with 10 Hertz. So this result here presented in quitting rate. You can see that at the end of treatment for this pilot study, people that got the 10 Hertz stimulation with a deep TMS, there was more subjects quitting smoking, and that effect was maintained over the long-term follow-up at 6 months. So this study was published in 2014 and was a pilot study, relatively small sample. So then Brainsway and Zangen decided to go for a larger clinical trial. And so here they did a multi-center trial. And so this is the design of the study. So mostly people got deep TMS or repeated TMS, here it's written, daily for 5 days in the week for the first 3 weeks, and then for the next 3 weeks, 1 stimulation a week. And then they monitored, ability of people to quit smoking, or their craving for cigarette or withdrawal at different time points during the trial. So this was a very large clinical trial. You can see here probably the largest TMS study in addiction. So you had 123 subjects in the active group, 139 in the sham group. You can see here that people were like smoker for a long time, average around 26, 27 years. They were smoking around 80 cigarettes per day. All had strong desire to quit, and a large percentage had tried multiple times to quit before. So this is here the summary of their finding, and shown here as 4-week continuous quit rate. So that's when you measure like at week 6, for example, or week 18, like are people like able to quit in the 4 weeks before the assessment. And the results here are shown as either ITT intent to treat or CO, that's only the completers that completed all the steps of the study. So you can see clearly, like in the sham group, there was very limited number of people able to quit smoking in that study, and those abstinence rates were almost triple or quadruple in the group receiving the active TMS study. And this was shown at a different time point, and also regardless if you study as an intent to treat or completers only. And during the same study, they measured the craving score or the cigarettes per week. So you can see there was a trend to have lower craving score or decrease of cigarettes, but it is a bit less impressive on those measures. It is really more on the ability to enhance the abstinence rate that they found their most significant findings. So based on those two studies that I have just shown you, the company Brainsway has been approved by the FDA for the use of TMS for smoking cessation, and that was in 2020. And in 2022, approval has been provided by Health Canada to also use this Brainsway coil for smoking cessation. So this is now treatment modality for smoker. So if you are like the majority of my colleagues working in smoking cessation, you probably did not know about approval of the Brainsway coil for smoking cessation. And so we are in this very interesting situation where we have a treatment modality that has been shown effective by studies approved by the regulator, but it is not yet much disseminated in the real world. And so if you want to know about what could be the next steps for translation and implementation into clinical practice, like my colleague Victor Tang wrote recently a very good review on what could be those steps to facilitate the dissemination. But so I will not go into the detail on those different steps. I would like instead to finish with presenting some of the data we have just published on testing like an Insular coil and testing it in combination with varenicline for smoking cessation. As you know, varenicline is pharmacotherapy that is widely used and is considered the most effective treatment approach currently for smoking cessation. So we were thinking that there could be value of associating varenicline with an Insular deep TMS. So that's what we have tested here. So I will go briefly on the design of the study. So we decided to do a randomized double-blind sham controlled trial with the idea of recruiting around 50 participants, smokers willing to quit. And we will randomize those smokers to either sham TMS or active TMS, and we will be using an Insular selective coil. And we decided to treat all participants with open label varenicline for 12 weeks, which is a standard treatment, and give them a 20 TMS session bilaterally, so mostly 5 days a week for 4 weeks. And then there will be like weekly visits to follow them up. So that's mostly the design of the trial. So different measures collected at different time points. The quit date was set at the end of week 2. And our main outcome was at week 12. In red here, the 7-day point prevalence abstinence, which means like people that didn't smoke 7 days before the assessment and that was validated by biological measure, were considered abstinence. But we also measured like abstinence at the end of trial. So those are the type of stimulation parameter we use for the deep TMS. So mostly practically speaking, what is important to remember here is we use eye stimulation, and mostly stimulation duration was around half an hour per subject. So we used also very open, like inclusion-exclusion criteria, allowing people that had comorbidity, for example, mental illness, to be part of the trial. Because typically, like lots of people that have mental health problem are excluded from trial, and we wanted to have a sample representative of typical smokers. So as I mentioned, our main outcome measure was a 7-day point prevalence abstinence at the end of 12 weeks, but we also measure a bunch of other outcomes. So this is the flow chart, the consort flow chart. So you can see here, like we started with lots of subjects like contacting us, around 600, and we screen a certain number of subjects to go down to enroll around 50 subjects, and around those 50, we were able to randomize 42 to either active or sham. So we ended up with a 24 participants in the active TMS group and 18 in the sham TMS group. So this is some measure of their demographic. So they were around 43 to 46 years old. There was no difference in terms of their CO measure, cigarettes per day, alcohol consumption. So they were smoking around 17, 19 cigarettes a day on average. Okay, so this is the main result of our trial. So when we measured our primary outcome, which is point prevalence abstinence at week 12, so we found much higher abstinence rate in the group receiving the combination of active TMS of the Insular and varenicline versus the group receiving sham TMS and varenicline. So we were quite pleased to see a significant effect here. But when we plotted all the abstinence rate at the different time point, you can see we found no difference on the abstinence rate at the week 4 and at the week 26. So it seems that this effect may not have been prolonged long enough, so which suggests that maybe we need to enhance the duration of the TMS session to produce a more long-lasting effect. And those are all results on the craving score on the left and the number of cigarettes per day on the right. So you can see those were non-significantly really different between the two groups during the different time point measure. Okay, so we are coming to the end of this presentation. So mostly I wanted to first introduce you to the current description on how different brain areas are involved in the neurobiology of substance use disorder, including like nicotine addiction. And I hope you have understood that since this paper from Nagvi and Bechara group in Science in 2007, there have been a growing interest of the role of the insula on addiction. So there have been clear findings suggesting that human subjects that have insular lesion are able to quit smoking and maintain that over time. There have been also preclinical studies selectively involving the insular area in nicotine seeking, nicotine taking, and lots of imaging studies showing activation of insular cortex in human subjects in association with drug addiction processes. You have also now clinical trials that have shown that insular prefrontal cortex deep TMS using a coil from Brainsway is effective to help people quit smoking, and this has led to an approved intervention by Health Canada and by FDA. There are still lots of challenges that remain in this field because this novel therapeutic intervention is not yet disseminated much. There are limitations based on cost, based on the infrastructure required, training people on how to use TMS coil, And then we don't really know much yet how to use it in the real life. Like, should that be used as a standalone intervention? Should that be used in combination, for example, like pharmacotherapy plus TMS, as I mentioned? And what is the exact place of this intervention in the continuum of care? So also those are open questions that will need to be addressed in the next few years. I didn't cover this also, but there have been lots of other research done on testing the insula in other addictions, for example, alcohol or gambling or opioid and so on. And there have been some promising findings in some area, but also some studies have been negative, like notably an Insular TMS trial that was negative for alcohol treatment. So I would like to thank few people in my lab over the years that have worked on this, and mostly their name are put in purple here. So they were involved mostly directly or indirectly in the insular work that we have been doing for the last 10 years or more in the lab. Thank you all for your attention.
Thank you so much, Dr. LaFolle, and good morning, everyone. My name is Christy. I am the Knowledge Translation and Implementation Coordinator with the Waypoint Research Institute, and thank you for joining us this morning. I certainly learned a lot, and I hope that you did too. So we're going to take some time to go through some of your questions. So the first question is this treatment covered by ODSP or ODB for someone on Ontario Disability Drug Benefits?
So at the present time, it's not a treatment that is covered. So there is no code that have been developed yet by the public system. So this is offered by few places and is completely out of private cost. At least in Canada, in Ontario.
Wonderful, thank you. There's another question about, someone's curious about the anticipated or observed side effects of RTMS on the insular cortex, in particular and other neural pathways involving the insular cortex, for example, romantic relationships.
Yeah, so the studies speak for good tolerability, mostly no side effects on the long run affecting, like, motivation or desire also to take food, for example, or like it was very interesting, like to me, like how would those things work, because insular cortex has been shown also to control, for example, gustative function or time perception, lots of functions. So it was really unclear, like what would happen when we modulate this insular cortex activity, and the clinical trial have reported good tolerability overall.
The next question is, how does deep TMS impact other functions of the insula?
Yeah, so it's still relatively unclear, like how is that functioning? And so one, and you, as you have seen in the smoking cessation trial, like in the brain swell large-scale smoking cessation trial with TMS alone, like the intervention is given initially for 3 weeks with almost daily stimulation, and then once a day, and then the effect is prolonged over several months. So there is likely some form of brain plasticity that is happening in the system, and the system gets changed somehow. And what we think, based on our varenicline TMS study, is that those effects may be different from what pharmacotherapy produces. So pharmacotherapy is probably very good to control, let's say, withdrawal and the basic, from immediate need led by the lack of exposure to nicotine, for example. But on the long run, it's not necessarily so effective, and lots of people relapse along the way. So maybe there is value of combining, interventions that will tap into different systems and then have synergistic effect. But how is this like neuroplasticity developing, and how long does that last? Like I would be very interested to measure like the brain function or neurotransmitters in the insula at different time point of people that receive TMS. And so what we have started to do in the lab, and we started to publish on this, is to look at spectroscopy, which is an imaging technology that allows to measure neurotransmitters directly. And we have done some control experiments so far to measure like how reliably can we measure those type of substrates in the insular cortex over time, repeatedly over the same subject, so that we can determine like is there like enough stability of the signal to measure those type of change over time. So that will maybe be the next step for us.
There's another question about the bioethics dimension of this work. So wondering what some of the unique bioethical issues or considerations are emerging in this treatment.
Yeah, so as always, will it be for preclinical studies or for human studies, we need to get ethical approval, either from an animal care committee or from an ethics board. And so those are questions that are addressed early on when we develop a project. Like, is it worth, in a sense, the risk or the pain for the animals or the human subjects that will be part of that? So, but there is currently support for use of non-invasive stimulation method to treat smokers, because we know that currently around 50% of smokers will die directly from consequence of their smoking behavior. So there is a huge impact on health of smoking. And we know that currently majority of smokers also want to quit, but vast majority are not able to quit with their current treatment approach that exists. So lots of people relapse and are not able to maintain abstinence. So we have a huge challenge of how to help those people, and knowing that half of them will likely die on the long run from their smoking behavior. So that's why like ethical committee usually find it's okay to test those techniques, because on the long run, they may not be associated with much side effects, and they may have also some benefit for the subjects.
Well, thank you. The next question is around genetic markers. So is there a potential genetic marker that would predict success or failure? For example, motor connectivity. Should we assume that motor connectivity is highly heritable?
Yeah, that's a very interesting point. So, and we know very little of what will be the predictive factors for treatment response for TMS. And it's very difficult to study this because the sample size have been relatively limited so far on those clinical studies. So if you're interested by this, like Dr. Tang just got a manuscript accepted on what could be predictor of response to TMS in this smoking cessation trial done by Brainsway, and the paper will come out in brain stimulation in the next few weeks.
We have one last question just to expand a bit on the neuroplasticity piece and how it's connected to mood, if it's possible to improve mood.
Yeah, so as you know, TMS is a modality that has been primarily used for depression. And it is quite possible that deep TMS would be an effective modality for depression as well. And so you could think that the deep TMS would be an ideal way to treat, smokers that have depression, for example. But those studies have not yet been done. Like in our study, we didn't really include people that had significant depression score. Like we had a few subjects that were depressed, but not so many that we can really study, is that an effective way to treat depression in smokers? So that could be very interesting study to do secondarily, like for people that have comorbidities.
Thank you. We still have time for questions, so please feel free to add them to the chat or the Q&A box. If there are no others, I may just ask one last question. I think that you expanded a bit on the challenges and around next steps at the end of the presentation, and you spoke a bit about a paper talking about next steps for translation and implementation into clinical practice. So I'm curious if there's anything you want to highlight there in particular.
Yeah, sure. I think, we have the advantage in Ontario that we have a publicly funded health system, which means that we could potentially provide those brain stimulation approach as part of the care system that is supported by OHIP possibly, and then the hospital. So there is a push currently to expand TMS for mood disorder as part of the rollout of, evidence-based medicine in Ontario and providing a bit better care for people with depression. So ideally, you could think that as there is a rollout of TMS that will be done in Ontario, hopefully place like Waypoint will be able to deliver TMS for people with depression or other mental health condition. And part of that will be possibly providing TMS for addiction care as well. So I think there will be opportunities to provide innovative treatment in the future for patients with substance use disorder, but we are still very early on. Like so far, it has been studied in research study, not really in real world. So we need to see how will that translate into real world effective treatments? Will people be interested to do that? Because, it's very demanding. So for the subject in our trials, they had to come like daily for several weeks. So it's a lot of commitment. So they were willing to do that, and it helps some people quit smoking. So, but will that be feasible if people work and have other commitments? All those things needs to be determined. We also need to collect data on the cost effectiveness of those interventions, because it probably will be more expensive than, providing nicotine patch or a course of varenicline. So I don't think it will be cost effective for smokers that try for the first time to quit smoking. My feeling will be that very likely a lot of the work in smoking cessation will still rely on behavioral counseling, cognitive behavioral therapy or regular pharmacotherapy. But we have patients that are not responder to those interventions, that are treatment resistant somehow. And maybe those patients will need something more aggressive or more integrated, and TMS could be maybe a way that could shift some of their difficulty and allow them to get success. So I think those are the type of questions that needs to be tested in the future.
Sounds like a bit of a stepped care approach. I think you had a visual that looked a bit like that as well. Thank you. We have one other question. Just wondering that this might be highly appealing to folks who are pregnant or intend to be pregnant, and if we should maybe be focusing knowledge translation in that area.
Yeah, very interesting. Yeah, you could think that you bypass, the risk of exposure to the fetus, and because we know, for example, like if you give nicotine, there is an accumulation in the fetus, and so that has also some applications. So it could be interesting. I'm not really aware of any study done in pregnant women yet with TMS. So I think it will be an interesting area, but really likely to be done on the research.
Thank you so much for all your questions and for your wonderful presentation, Dr. Lafall. I, again, learned so much. I appreciated all the visuals as well. The rats were actually very cute looking in this presentation, not like in real life. But I just wanted to see if there's anything else you wanted to add before we move into our closing, or if there's any other questions folks want to add in.
Okay, so it has been a pleasure, and thanks again for providing the opportunity to present the work.
Wonderful. Thank you so much. So thanks everyone for joining us today. We really appreciate your time. Just a few quick reminders. We will have the recording and these slides available on our website post-event. We also have a post-event survey, again, that we really appreciate you filling out. This helps us guide our future events and learn more about what you're interested in hearing about. And again, you can reach out to me for a professional development certificate. My email is on the screen there, and I will also add it into the chat. This is available again after the presentation. And with that, we want to invite you to join us in February for our next Waypoint Talks. This is a Building Your Research Toolkit presentation around integrating implementation science into clinical quality improvement initiatives. And this is hosted by Dr. Zhang-Chang Zhao from the Waypoint Research Institute. So this will be on February 27th, the same time as today from 10 to 11:30 a.m. You can scan this QR code if you'd like to register right now. We will also send around the link for folks to register in the chat as we close out the presentation. So thank you so much again for joining us. Thank you, Dr. Lafall, and have a wonderful rest of your day.